Understanding chest radiology really comes down to understanding a web of relationships. And this web is governed by two very simple rules. Diseases produce imaging features, and imaging features point us back towards diseases. Sounds simple, but the problem is the relationships aren't one-to-one. They're not monogamous. One disease can produce several different imaging patterns, and one imaging pattern can be produced by several different diseases. That's what makes chest radiology hard. So we need a simple way to make sense of this web. There are basically two ways to learn it. The first way is to start with the diseases. Take disease A. We learn all the imaging features disease A can produce. Some of those relationships are really strong, some are weaker. Then on another day, we learn disease B, and we learn its imaging features. And the relationships quickly start to overlap. The second way to learn this web is to start from the other side. Start with the imaging features. We see imaging feature 1 and ask, what diseases can produce this? Then imaging feature 2, what diseases can produce this? That's the feature-based approach. And I think, especially when you're first learning chest radiology, it makes an enormous amount of sense, because think about what actually happens when you're on call. Nobody hands you a CT and says, here's disease A. Tell me which of its imaging features are on the CT. Instead, they give you a CT. That's the input. And they want to know, what do you see? And then, what does it mean for this patient? Maybe you see imaging feature 1. Your job is then to ask, what diseases might do this? Then you notice imaging feature 7 on the same study. And if you believe that both imaging features are caused by one disease, now the question becomes, what diseases might do both? And suddenly that huge differential gets smaller. That's the process. Now, disease-based and feature-based learning aren't competing approaches. They're complementary. Early in residency, I favor moving heavily from feature to disease. Later, as you know more pathology, you increasingly move from disease to features. And by the end of residency, you should be comfortable navigating across this web in both directions. That's our goal. There are two principles behind the feature-based approach we're going to emphasize. The first is pathophysiology creates morphology. A disease does something to the lung. That changes the anatomy, and the change in anatomy creates an imaging appearance. Different imaging modalities may reveal different aspects of that appearance better than others, but the underlying structural problem is the same. So the frameworks we're going to build aren't really chest X-ray frameworks or chest CT frameworks, they're lung frameworks. We can use them on radiographs, we can use them on CT, and when appropriate, we can use them on MR. The second principle is just as important. The images alone are not the diagnosis. The images are one piece of the diagnosis. We also need to know the patient. What's their history? Why was the study ordered? What happened yesterday? What are we worried about today? Because the exact same opacity in two completely different clinical settings can mean two completely different things. So we're usually doing two things at once, reading the image and reading the situation. Now let's talk about our plan for the next 17 talks. I've taken what I want you to learn during your first chest rotation and broken it into 17 modules. Each one focuses on a particular set of concepts and strategies for building differential diagnoses, the kind of problems you're actually going to encounter when you read chest imaging. The first 10 modules deal with the lungs. And before we start them, I want to give you a very simple model for thinking about lung opacities. The model I like is a Zeppelin. Zeppelins looked a lot like huge blimps, but internally they were very different. A blimp is essentially one large gas-filled envelope. A Zeppelin was mostly gas too, but inside it had this incredibly elaborate metal latticework, a fine structural scaffold that supported the whole thing. And that's actually a useful way to imagine the lung. The lung is mostly gas, but running through it is an extraordinarily fine structural framework or scaffold. And in the lung, we call that scaffold the interstitium. Now, if a normally air-filled lung becomes abnormally opaque, there are basically 4 things I want you to think about. Just 4. Number 1, consolidation. Normally, the alveoli contain air, but suppose that air gets displaced by something denser. Water, blood, pus, protein, inflammatory material, cells, whatever it is. We've replaced gas in a region with something denser. The lung becomes opaque. We call that consolidation. Number 2, interstitial opacities. Maybe the alveoli are largely air-filled, but the fine supporting framework, the interstitium, becomes abnormally thick. We call that an interstitial opacity. Sometimes that thickening produces lots of fine lines, almost like a spider web. That's a reticular pattern. Sometimes the thickening looks nodular. That's a nodular interstitial pattern. Slightly different appearances, same basic idea. The scaffold got thicker. Number 3, atelectasis and fibrosis. Now, go back to our Zeppelin. Imagine part of that latticework getting pulled or compressed into a much tighter space as the gas disappears. That region gets denser. Not because we filled it with stuff, not because parts of the scaffolding became thicker. We've simply packed the structure into less volume. That's volume loss. 2 important processes that can do this are atelectasis and fibrosis. Atelectasis is collapsed or incompletely expanded lung and may be reversible depending on the cause, while fibrosis is scarring and irreversible. Different processes, but for our simple model, both can increase lung opacity while reducing lung volume. Here's a crashed Zeppelin. Imagine looking inside of it. All that metal latticework is now piled tightly close together. Of course, it would look denser. Number 4, nodules and masses. Maybe the air spaces haven't been filled. Maybe the scaffold isn't thickened. Maybe the lung hasn't lost volume. Maybe there's simply new tissue there, a focal lesion. Up to 3 centimeters, we call it a nodule. Over 3 centimeters, we call it a mass. So, when lung appears abnormally opaque, ask yourself, am I looking at consolidation and interstitial opacity, atelectasis fibrosis, or nodule mass? 4 possibilities. Now, real diseases can combine them. 2 mechanisms can happen together, sometimes even 3, but that's okay because now you have an approach to making the lung thinkable. Instead of treating every opacity as a completely new problem, we can start with 4 basic possibilities. And 4 is pretty manageable. Now, if there is an abnormal lung opacity, there's always going to be 3 questions I want you to answer. What is it? How is it distributed? And where is it? Type, distribution, location. Let's start with the first question. This slide is basically a map of the vocabulary we use to describe types of lung opacities. And the idea is actually very simple. On the left are broad terms, and as we move to the right, the terms become more specific about morphology, sometimes more specific about chronicity, sometimes more specific about distribution. The most general thing I can say sometimes is there's an opacity. That's it. But maybe I know more. Maybe I can say this isn't just an opacity, it's consolidation. And sometimes we can go much further. This isn't just an interstitial opacity, it's a nodular interstitial pattern, and actually it's a centrilobular pattern. So we're moving from broad to specific. And what determines how far to the right we can go? Basically, information. A CT gives me more information than a chest X-ray. Prior studies give me more information than no priors. Good imaging technique gives me more information than poor quality images. And the more information I have, the more specific I can be. But the reverse is also true. If the information gets worse, we move towards the left. We become more general because sometimes the information simply isn't there. Give me a lousy portable chest X-ray, and I'm probably not going to tell you whether the nodular interstitial pattern is bronchovascular or tree and bud. I may not even be certain whether the abnormality is truly nodular rather than reticular. And that's okay. Maybe the most accurate thing you could say is simply there is an interstitial opacity. That's an important idea because if you listen to someone describe a chest X-ray and then listen to someone describe a chest CT, it can almost sound like they're speaking different languages, but they're not. It's the same vocabulary. They're just operating at different levels of specificity. The CT gives us more information, so we move towards the right. The chest X-ray gives us less information, so we move towards the left. Before we leave this slide, there's one term here I want to point out: ground glass opacity. You've probably heard that term before. And the important thing to understand is that ground glass describes what an opacity looks like on CT. The lung is more attenuating than normal, but you can still see the underlying vessels and airway walls through it. It's a special situation that can happen if you have consolidation that's incomplete enough that you can still see through it, or you have an interstitial opacity pattern that's so fine that it's below the spatial resolution of the pixels in your image. And when either of these things happens, the opacity looks partially transparent, almost see-through. That's what we call ground glass. So rather than thinking of ground glass opacities as some entirely separate type of lung opacity, I think it's more useful to think of it as a particular appearance that can arise from consolidation or from a very fine interstitial opacity. So first, we explain what we see. The second question we need to answer is, how is it distributed? At the broadest level, we can ask, is the abnormality diffuse, spread broadly through the lungs without a strong regional predominance, or is it non-diffuse, with clearly involved in relatively speared regions? And if it's non-diffuse, we can go further. Maybe it's focal, maybe it's multifocal. These words matter because distribution contains information, and information can change our differential. So, our first task was to explain what we saw and then how it's distributed. The third question we need to answer is, where is it? You probably remember this from high school. There are several ways to describe where a point is in space. Cartesian coordinates, x, y, z, left, right, front, back, up, down. Cylindrical coordinates, r, theta, z. How far out, which direction, what level. and spherical coordinates, rho, theta, phi. How far away and in what direction in three-dimensional space. Different systems, same goal. Tell me where the point is. For the lungs, I think one of these systems works particularly well. Cylindrical coordinates. Why? Well, because the lungs are much closer to cylinders than they are to cubes or spheres. Now, obviously, we're not going to dictate numerical values for r, theta, and z. We're going to use words. For r, how far out we are from the hilum, we might describe an opacity as central, peribronchovascular, or peripheral. Now, peribronchovascular doesn't literally mean the distance from the hilum between central and peripheral. It means the opacity follows the bronchovascular trees. But interestingly, lung opacities that aren't central and aren't peripheral are very often distributed along bronchovascular trees. So conceptually, we tend to describe opacities as central, peribronchovascular, and peripheral, the further away from the hila they are. For theta, which direction, we might use anterior, posterior, medial, or lateral. And for z, what level we're at, we might use apical, upper, mid, lower, and basilar. So it's basically the same idea as cylindrical coordinates. How far out, which direction, and what level are the opacities. We just replace the numbers with useful anatomic descriptors. And once you can answer these three questions, what is it? How is it distributed? Where is it? You've constrained the problem enormously. You've taken a complicated imaging feature and converted it into something much more useful you can start building a smart differential diagnosis with.